centralized NHI fund. Let's get into it. Dr. Donald, good evening.
Good evening, sir.
It sounds like an ideal world. I mean, it sounds like a world we all want to live in. It sounds like a world that today, let's change everything, let's turn the tables and let's go there. Is it realistic? As a principle, it sounds good. But in the real world where we're living with a growth of 0.8% in terms of the economy, is it all possible?
First and foremost, I would say it's not possible at this point in time because it requires huge amount of money to run a system like the minister has just alluded to. And we don't have that kind of money in the country. And if you read the bill closely and scrutinize it, it talks about them even have to go to the people to look for taxation. So you still have to collect the money first, and then that's why it's not specific, the bill. Yeah. It doesn't tell you how much it's going to cost. So like a QS, if you're building a building, you need a QS who will tell you, you need 500 bricks to build this structure, you need this, how many tiles or whatnot. And at this point in time, it's not a well-oiled machine. And unfortunately, like we had attended the presidential summit, we had people from WHO who presented different models of universal healthcare. Most of them, they don't work. I mean, we're talking about first world countries, your America, your UK, your France, and everybody. And now we are probably the third world country where tax collection is not up to standards. And you still have to actually beat the private sector to give you back the incentive, the tax incentives that you were giving them of around 40% to put it back to the NHI coffers. So it's very, it's idealistic, but it's not practical at this point in time.
Let's give you an opportunity here to also breathe and air your views. It looks like on paper, there is an agreement, even with associations, but even with doctors at large, that the two health systems in the country, which are unequal, is not sustainable. It's not something that we would like to have. So we would like to move into a system that is more equitable, where even the poor can get the same quality of healthcare that the 16% or so are able to get in terms of how it's structured currently in the country.
Yes. Look, the question you asked, is it the right direction? Is it the right thing for the country to do? Considering the fact that, we have a parallel healthcare system, the private and the public serving about, 82–83% of the population, and the private about 18% of the population. And both of them are in trouble. The public health sector, the previous minister said it's in ICU, all right? Yeah. So we all know that there are challenges there. Yes, there are pockets of excellence, but largely it's not doing well. But people also think that the private healthcare sector is actually doing well. No.
Well, they call it the world-class private healthcare sector.
No.
It's not the Rolls-Royce of healthcare sectors.
It isn't. If one can just read the interim report by Judge Ngobo, for the Competition Commission, the Health Market Inquiry, you will find a lot of rot that is driving the cost of private healthcare to unsustainable levels, all right? Where costs are going up, there's a lot of, over-servicing, unnecessary procedures,
right.
And cartel behavior.
Right.
And
so put in simple terms, people are paying more for less.
So people are paying more for less.
Yeah.
And some of the schemes are starting to get the financial strain. So therefore, both the private as it is and the public as it is, are not sustainable.
Right.
And therefore, there is a need to come with a new solution for the country. And because we're a member of the WHO, all member countries are supposed to have, universal health care by 2030. And so it is a good thing to have an NHI. So the principles are noble.
Yeah.
But I think we need to go beyond the noble principles to look at the practicality and readiness of our country, especially when we are staring, another junk status situation, and see whether the coffers of government to pay for the indigent, the unemployed, and the elderly are actually going to be able
Dr. Nyati, one will listen to you and say you speak like an administrator.
Yes.
An administrator of these medical aid schemes.
Yes.
Of course, they stand to benefit by maintaining the status quo. They don't want this thing to go away.
Yes.
You want to have a centralized fund. I'll give you another bite at it.
Okay.
But Charlton, let's bring you in. Do you want to have a centralized funding structure, or are we imposing a funding structure of developed countries? By the way, in developed countries, it's also not working, if you look at what's happening in the UK. But we are putting it on South Africa, which is a developing country with a very low tax base.
Okay, so I think my first point of departure is the point that people are saying it's unaffordable to have NHI. If we take a closer look at how the bill has been presented and how they want to implement it, it's not going to be an immediate thing to move from this health system and have an NHI fund working overnight. So it will be a process which will take place in steps. And people are saying, what about where the money is going to come from and so on. So the way it's going to be implemented, it will be such that we first of all start redistributing the money which is currently being spent on healthcare over time while you restructure the system. The health system is complex and it takes a lot of time to actually get things right.
So here's my concern. While you're there, speaking about distribution, I read this thing and I get a sense, right? Especially if provinces are no longer going to get the money. National is going to take this thing and put it in a kitty somewhere. It's going to be controlled. So I don't know. This is my thinking. Money that is meant to upgrade hospitals, which currently need a lot of upgrading. Buildings are crumbling and falling apart. There are no beds and so on and so forth. Will now no longer go there because now provinces will no longer be directly funded. They will have to provide services first and then go to the centralized fund in order for them to be able to grab that money.
So it's not going to happen exactly as you are saying.
Okay.
The funds which end up going to the provinces to be spent on healthcare are going to still go to the provinces to be spent on healthcare. What is important now is the separation of the purchaser and the provider. Currently, the provinces are the purchaser and provider, and that creates a lot of inefficiencies in how the money is spent. But when you have a separate purchaser, which will be your NHI fund, they're able to exercise more oversight over the provinces to make sure that every rand which goes there is well spent. And we really need that. If we look at a lot of health systems, that is how they are actually structured. It brings in more accountability to the provinces because you want money, what have you done with it? There's that relationship which can be managed. And we need to have that culture happening at the provinces.
Why must we believe them that they can manage it now, Charlton?
Sorry?
The public sector is in shambles. Why must we believe them now that we're going to give them this fund, they're going to behave differently and they're going to do what they're supposed to do?
So I think they are actually in shambles because of the way it's structured now, where the provider of the service is also the purchaser.
Explain that to me.
So the province gets an allocation from national government, and then it has to build the structure, and then it also has to provide the service. There's no one who's making sure that every rand is being spent as it is supposed to.
That's exactly
because
my question.
that's
So
the province.
why are we to believe that they're going to behave differently now?
So-
because it's still government that is going to manage the fund. It's not some odd person that's going to come from the sky and come and manage this fund.
So when it's a fund which is now managing the money, it will be a separate board with separate governance structures, which is supposed to run in a more efficient way because the board is separate from the service provision.
The board will run in a more efficient way. What do you say?
Well, look, this bill is really about setting up that NHI fund, which will then have the relevant structures from the board, the subcommittees of the board, CEOs and advisory committees and all of that, all right? But at the end of the day, we are looking to create another SOE. Now, as a country, if you look at what is happening now and the past decade or so, we have not done very well in terms of efficient running of SOEs. And so a lot of South Africans, whilst they are in support of the NHI as the principle, they worry about more the implementation. Yes, it's going to be a phased implementation with a target date of about 2026.
That's right.
Mm-hmm. However, money is going to be spent, from now going, increasing towards 2026. And the question is, will that money be used efficiently to improve the quality of services that people are getting on the ground? And that's where the concern is.
Money is going to be spent. Will that money guarantee that people are going to get the quality of health care that they deserve? Quick one, Dr. Gumede, before we go on the break, in 30 seconds. Yeah. How much is this thing really going to be? 452 billion. There are others who are estimating this thing. I think the IRR says it might even escalate to about $1 trillion. I don't know if we believe that it will go up.
Correct.
Go up.
But just maybe before I answer that question, we should be realistic here, because we are sitting with doctors who are sitting at home. We are sitting with dilapidated hospitals. As I'm talking today, the Gauteng government doesn't have family planning treatment or drugs.
Or programs.
Yes, you see. So I agree that the NHI thing is needed. But then the issue also of the utilization of the funds is very critical. It's very important, because even the little that we have, are we using it efficiently? Or we're misusing the funds?
Even the funds that we have, are we using them efficiently, or are we misusing the fund? Let's hold it on that thought and take a break. It's a conversation on the NHI. All you need to know, Dr. Donald Gumede, Chairperson of the National Healthcare Professionals Association, with us. Dr. Fundile Nyati is a health expert, and he's also from Proactive Health Solutions. And we've got Charlton Murove, Head of Research at BHF. More when we return from the break here on Newsroom Africa, Channel 405. All right, you are on Weekend Prime. This is Newsroom Africa, Channel 405, and the discussion is on about the National Health Insurance. Joining me is Dr. Donald Gumede, Chairperson of the National Healthcare Professionals Association, Dr. Fundile Nyati, a health expert, and Charlton Murove, Head of the Research Unit of the BHF. And of course, before the break, discussing whether or not the funds that we currently have are being used properly to be able to meet the needs and to be able to take this particular health care system that we have in the country to new heights. Are we doing enough?
Yeah. Let me put numbers to it. The health budget, or Department of Health budget, is around 213 to 25 billion, somewhere there. And then, like Dr. Fundi said, it's distributed federally, meaning our provinces, like you alluded, they're federal, meaning they're independent.
Yeah.
So this budget goes to, according to demographics, like in Gauteng, maybe we've got 12 million people. So it will have a certain percentage that is allocated, and then KZN being the second one, 8 million, and then Limpopo, 3.8 million, like that. Now, we are having these shortages of these resources because most of the time is the misuse of the funds. When I was in Limpopo, they were at the deficit of 4 billion by last year, before the new budget came in. Yeah. And in Gauteng, you saw recently they're sitting at around 1.2 billion in legal litigation, so there's too much pressure in the health system. Now, if you were to ask me whether I welcome the NHI bill, I'm happy about it, because why? What many people don't know is that even if you're in private, the government still subsidizes you, your medical aid.
Right.
Because they give rebates into your employer to be able to subsidize your medical aid of around 40%. So if that money goes back to government, then it will bolster the fund as well.
Yes.
Now, we'll be sitting at maybe 400 billion, I'm just giving give or take. Yeah. And in that, I believe it will improve what you alluded earlier on, infrastructure. Right. Because in the President's Summit, we're talking about the infrastructure, human resource, and the private sector. Yes.
Here's what I want to do. Some breaking news right now, Dr. Gumede. Hold that thought. Of course, we are awaiting the arrival of the former public protector, Thuli Madonsela, who literally has climbed mountains to help young women in need. Okoko Dlamini. She, alongside with the National Nelson Mandela Foundation CEO Sello Hatang, were part of a group to successfully summit Mount Kilimanjaro and are expected to touch down in South Africa this evening. Now, Pilani Pakhadi is at the airport right now. Pilani, what are we learning this moment?
Well, I mean, this is a very important initiative, Aubrey, and I have to tell you, I mean, I'm already also being a bit envious of seeing the former public protector coming through, because, I mean, that's the successful summit of the Mount Kilimanjaro, the tallest mountain in Africa, would simply mean that young girls will be benefiting from this. But of course, I mean, as we are now waiting for them to come through the arrivals terminal right now, I'm just going to be stepping into shot and ask Nkateko here. She's from Imbumba Foundation. That's the foundation that stands to benefit from the successful summiting of Mount Kilimanjaro. Just to share with us their excitement as they're just waiting for the former public protector, the Nelson Mandela Foundation CEO, Sello Hatang, among other things. How's the excitement coming along?
Thank you for having us. As you can see, there is so much noise. Everybody's excited. The climb this year, the plan was that as soon as they come back, they land. Already over 750,000 girls will benefit from this climb. And by the end of the year, 2019, we plan to ensure that 1 million girls will be kept in school. The excitement is obviously because the families are here. They want to make sure and ensure that the climbers are happy and safe, you know? Yeah.
Aubrey, I can tell you. I'm just going to show you some young girls here who also stand to benefit from this particular successful summit of the Mount Kilimanjaro. They are waiting for the former public protector, as well as the Sello Hatang from the Nelson Mandela Foundation, as well as the group that they summited with, the Mount Kilimanjaro. So the spirit here is a bit, you can see, the mood here is that of happiness. Perhaps I should also get in shape one day, you and I, Aubrey, and also attempt to summit that particular mountain. What do you think?
Yeah, Pilani, you need to get in shape. Firstly, you need to know that you're not talking to Aubrey, you're talking to Thabo, but I'll let you go this time around. You need to get in shape so you and I together can go summit Mount Kilimanjaro. Well, as soon as the Trek for Mandela crew lands, we'll get back to Pilani there and get that update. But let's continue now with our conversation here. Dr. Nyati, you were itching to just jump in there. The right rate, the right price, the right reason, the right funding is what we are looking for. And therefore, let's separate what is the funding component from the delivery of services. And then, of course, talking about the governance.
Yes. Look, as a country, if we now look at the total expenditure as a country, you know, on healthcare, somewhere around 8.5% of the GDP. And when you look at that, it's comparable to most, you know, developed nations, you know, your Germany and other countries, okay? So at that level, we're spending enough, but we are not using the money that we are spending on healthcare in an efficient manner, such that every citizen of South Africa can be able to be guaranteed quality services.
So the argument is, let's spend a lot, in fact, this NHI, as it starts, on primary health care. Because there are people who spend a lot because they end up going to hospitals for things that they don't need to be in hospitals.
And that's logical, because, you know, a healthcare system should have a strong primary health care. Because that's the first point of contact. You know, when people are sick, with primary health care. And then they get referred secondary, tertiary, you know. So, but the history of our healthcare system pre-94 was such that it was very much curative type of healthcare system that relied on reactive interventions. And so we are trying to change that to focus on preventative healthcare, which is cheaper in the long run. But unfortunately, the clinics, even the ones that have been newly built, some of them are white elephants because the staffing and the equipping of some of these clinics is actually
So Charlton,
a challenge.
and that's the question. So how do we make sure that the medicines that are supposed to be delivered are delivered, they're not stolen, the syringes that are supposed to go where they need to go are there, and the staff and the expertise that are required are there, particularly in the public health care? Because what you're going to have here is a situation where, again, people will prefer to go to the private clinics instead of going to the public clinics.
So the NHI is actually an opportunity to correct all these mistakes. I'll first respond on the issue of governance. I think we want strong governance, we need strong governance, and it's actually more important at this point in time. So my message would be, let us all look at the bill while it's being debated in Parliament so that it presents a strong governance structure so that it does not become another SOE. And everyone should actually pay attention to that. Then when we have good governance and NHI starts working as it is proposed, you'll find that it becomes easier to have all these challenges solved. The NHI, for you to be accredited as a service provider, you'll have to meet certain standards. And those standards will include you have the right equipment, you have the right personnel. Yeah. And it can be anything, either the public or the private. So already it opens up the amount of resources which are available for the fund to pay for health services. So the problem is not exactly as big as you say. And then on another point, I want to address the issue of cost. We don't know what the benefits are at the moment. So you cannot tell what the cost is. The fund and the board will be managed in such a way that the benefits and the funds available will be in tandem. They will not offer benefits which are unaffordable. Okay. So the fund does not pose as a risk of promising too much when there isn't enough money. So the issue of affordability shouldn't be focused on too much. Yeah. You will provide what is affordable, and it will start at a primary care level and then build up onto more comprehensive benefits.
Is laughing. How do we determine what is affordable? Currently, there are about 250 odd or so ailments that medical aids are supposed to be paying for, right?
Sure.
Because my last conversation with the doctors, they said, previously you used to have somebody who determined how much these things are going to cost.
100%.
Now, doctors kind of determine themselves how much these things are going to cost.
Exactly, yeah. Let me disagree with my colleague here. On that issue. You know, previously the doctors, we used to have where you have associations and your RAMs and whatever sit down and discuss how much it's going to cost if I saw you with an eye infection. Right. And as we were talking with Dr. Fundi before the meeting, that committee, the tariff committee, has not worked in the past 10 years. So it's not there. So we're hoping that miraculously it will resurrect and start having these tariffs. Because you cannot open a shop without pricing. Right. It's not going to happen. Yep. You know, if I get into your shop, I need to know how much is the bread and how much I'm going to pay for the milk. I must know. Now, that we have not got into that stage as well. And again, the reason why there's a confusion is because when NHI comes into play, it means the medical aids are going to be what we call gap top-up. Yeah. Yes. Yeah. So meaning NHI will provide a certain basic of whatever to say, okay, we can provide up to this level, but beyond this level we can't. Then you're going to need that medical aid now to kick in and then top up and says, okay, we'll handle these issues. So we are actually moving at an uncharted world at this point in time. We are theorizing things. And I must mention that there were many pilot projects which were done with NHI. All of them failed here in South Africa. Right. That's why even those results were never published, you know, because they failed.
But isn't this a perfect opportunity, I suppose, for the medical aid schemes to come on board and play ball here? Because previously they've been saying, well, I mean, I can't bring my prices down because if I'm going to bring my prices down, the competition is going to thrash me. So literally what this NHI bill now provides is to say government is going to say everybody's now on equal footing. You're all going to get the same amount of money. So, well, let's see. Let them put their mouth where their money is.
True. You see, actually, that's what the aim up is all about. Because last year when we were doing the stats, 16% of the population in South Africa it was covered by medical aid. And then the rest of the 84%, it was going to public. But remember again, the medical aids by June, they're finished, majority of them.
Yeah.
You see, so actually they're exhausted. Okay. Now, you are sitting with a situation whereby you are glorifying this private sector, which you said is working well, but actually it's not.
Let's talk about that, what's happening in the private sector and what is going wrong, and I'm going to give Dr. Nyati an opportunity to respond as well. Let's take a break. It's Weekend Prime, it's Newsroom Africa, channel 405. A discussion on the national health insurance continues when we return. On Weekend Prime right now, conversation going on about the national health insurance, joined in the studio by Dr. Donald Gumede, Chairperson of the National Healthcare Professionals Association, Dr. Fundile Nyati, a health expert, as well as Charlton Murove, head of the research unit of BHF. Now, when we talk of, Dr. Gumede, of the parallel healthcare systems, when we speak about the public sector, we speak about lack of infrastructure, we speak about wastage, human resource, you name it. And when they talk about the private sector, they say less queues. This thing is fantastic. There are beds, there's technology, there are specialists, and so on and so forth. How huge is the service offering gap between the two sectors?
It's very huge. That's why even in that health summit, actually the private sector had offered to 13 million beds, actually, to the government per annum, of which I asked at what costs. And then they offered also to train nurses, because they're doing it, especially net care, they're training nurses. Because naturally here in South Africa, we produce very good healthcare practitioners, to be honest. That's why they can work anywhere in the world. So, but having said that, the gap is very huge. If you look at private and you look at public, public is dilapidated. It doesn't have human resource. If someone resigns now, the post gets frozen, as I'm talking to you now. Yeah. And it's not frozen because there's no work for that particular healthcare practice. It's frozen because there's no money to pay that particular person. Now, that creates long queues, because you find that in casualties or in the OPD, you're supposed to have 5 doctors, but only 2 are there. So if you are seen by 2 doctors instead of 5 doctors, you're going to wait longer. Yeah. But then if we capacitated our hospitals properly, we'll have less queues. And you wouldn't have to wait for long to be seen by a healthcare professional, even in public. Now, the NHI, I understand, is trying to address that, because it's saying instead of everybody going to the public, they can come to the private practitioners to be seen by private practitioners as well at a fee. Yeah. So, but then the sustainability of it thereof, we shall see. But then having said that again, the gap, as I'm saying, it's huge, because in private practice, it's money. Money speaks. If I have money, I mean, I can get any service.
Dr. Nyati, your views on the service offering disparities?
All right. Look, one thing one can say about the private health sector is that the resources, infrastructure, equipment, human resources, are there. All right? So you will get the care. The challenge is just the costing of that care. That tends to be, increased unnecessarily through certain incentives, which then create a spiral in terms of the cost of that service. So that's the thing that needs to be addressed in the private sector. So even when now we have an NHI, private health facilities will be accredited. They will be able to see patients, who belong to the NHI. Right. But the worry is, because, people are used to inflating costs, are there systems in place to make sure that they don't drain that NHI fund?
So, Charlton, you are saying to me that the board will then sit and say, to be a part of this club that is able to benefit from this fund, Your hospital needs to have clean running water, needs to have a backup generator, it needs to have so many beds, they need to be proper, they need to be, and so on and so forth. Unless the public hospital belongs in terms of those criteria, then it can't benefit from it.
Yes, so that's correct. And the idea of the NHI fund as well, it's not going to buy services from the providers at the current rates.
Yes.
In the bill, it clearly states that the prices shall be determined. So we go back almost to a negotiation of some sort to make it sustainable. So quality of care will be important. It might even be value-based care where you don't pay for things that are done, but you actually pay for treating the patients, which changes the whole dynamic and brings in more efficiency. So the problems that you are highlighting are the exact reasons why we should be looking at NHI as a solution and looking at the bill to make sure that it is the effective vehicle to deliver the care we need, right? It is quite ambitious, I agree, but where do you start? You have to start from somewhere, and this is just one small piece of legislation which will enable us to get there. There are other changes that are needed in terms of legislation to get to the full suite where you have a comprehensive
and let's talk a little bit about that, Dr. Gumede, because these are two bills that are being presented. It's this one on NHI. There's also the medical schemes amendment. What is that about, and how does it assist in getting us where we need to get to?
Yeah, actually, if you check, you read the NHI also, it calls the bills, the medical aid scheme bills and whatnot. So both bills are important because, you see, the private sector was not well regulated. And that's why what Dr. Nyati said happened, where the exponential proliferation of costs just spiraled, shot up. Because in truth, in private, they spend more in less number of people than in public. So actually, if we were, like the point that he mentioned, our GDP expenditure, if we're using that money collectively, both private and public, we should be having a 5-star health system in South Africa, to be honest. But because people are not looking at delivering service to the patients, they are looking at their pockets. Even now, at NHI, there are people who are already positioning themselves in some stop sign somewhere to collect monies. And that's the problem. As long as we can stop embezzling this money, which is meant to improve the lives of the patients, then we'll have a proper healthcare system. And then that
sustainably. So are we not looking at spending ourselves into bankruptcy here?
You see, like we are saying, as long as there are checks and balances which are correct or which are right, we can sustain this because we are within what is required by WHO, the 8 to 9% GDP expenditure for health. It's just that we are not using it properly. We are using it like in private, like I'm going to refer to it. Majority of the money is spent on bonuses and administration, not in patients. You know, so as long as...
So how do we curb the administrators' appetite for profit? Because the schemes themselves, essentially, my understanding is that they're not meant to be for profit.
Correct.
Right? It's the administrators, on the other hand, who are profit-driven.
You're very right. But then you see, the problem is this. As long as you have people who want to break the laws and create a money-making scheme within the system, we'll have this problem. And in South Africa, we are good at it. Like if you check, like you have just said, schemes are NPOs. They're non-profit organizations, but they geniusly created administration to make sure that they make money. And they make huge profits. And the commission that was headed by Judge Ngobo, that we keep on quoting, that report was supposed to have been, the health market inquiry, was supposed to have been released long time back, you see. And then the remedial actions were supposed to have been taken long time back. But because people who have good pockets and good connections are there, it's stuffed. And then now they said it's going to be released on the 30th of September. But then the remedial system actions, if we went and persuaded the government to enforce those remedial actions, the cost will go down. It's a fact. It will go down.
Charlton, have we reached enough consensus to make this work, do you think? Because I know the green paper was in shambles. They sent it back. It came back. It was a white paper. It was in shambles. In 2018, a white paper was made public. The public had contributions into it. Are we at the point where we had consensus enough within the sector to make?
So I think, I don't think we can say the bill is perfect now, but I think we've made significant strides in terms of trying to improve it. Hence, my encouraging is let's look at the bill together as a nation, engage with it, and make sure that it delivers a vehicle which will provide a proper functioning NHI. And I think that's the important thing that we actually need to look at the moment. And then on the issue that was raised by Dr. Gumede, or the costs and what's happening in the private sector, yes, it's quite costly. And that's why we are saying we need reforms. And then if you look at the cost drivers, I won't say it's just the administrators. You can look at the hospitals. You can look at even the providers themselves. I mean, there's public information of where money is spent. So it's quite an inefficient system, the way it is structured. Hence, we need to actually reform to get a more efficient health system.
Gentlemen, we're out of time. Let me thank you so much for coming through.